Dr. Slidevska will talk about also radiation oncologist. National Cancer Institute will talk about external beam radiotherapy and in prostate cancer. So please, you can start.
Hello, I'm Kristina Slidevska. I am radiation oncologist and I'm going to speak about external beam radiation therapy for prostate cancer. In our department, we have a CT scanner dedicated for radiotherapy for Linacs. 3 of those are Linacs dedicated for stereotactic radiotherapy with optical surface monitoring system, OSMS, for patient positioning. A little bit statistics. We treat about 2,000 patients each year. More than 200 of those are prostate cancer cases. Nowadays, evidence-based radiotherapy consists of literature data, physicians' experience, the best available equipment, and what are patients' values and beliefs. So, prostate cancer radiotherapy, where are we going? Large randomized phase 3 hypofractionation trial, such as CHIP, conventional or hypofractionated high-dose intensity modulated radiotherapy for prostate cancer, and HYPRO trial showed that hypofractionated external beam radiation therapy in 2.4, 3.4 grays per fraction is equivalent to conventionally fractionated 2 grays per fraction radiotherapy. Around 2018, the schedule of 20 times 3 gray in 4-5 weeks became the new standard. In light of these findings, the conventional 70 gray dose is no longer considered adequate. For cases under 80 grays in conventional fractions to the prostate with or without seminal vesicles is appropriate for low-risk cancers. Intermediate risk or high-risk patients should receive the doses up to 81 gray. So conventional 80 gray dose to prostate is common and safe. Studies have shown that dose escalation is safe in certain clinical situations. Freedom from biochemical or clinical recurrence was higher in group randomized to 80 grays compared to 70 grays. There is only minor increase of toxicity. So dose escalation is safe implementing modern external beam techniques. Another topic what is discussed and prevalent among radiotherapists, especially in the context of the current COVID pandemic, is hypofractionation. Moderate hypofractionation is from 2.4 to 4 grays per fraction. Randomized studies for moderate hypofractionation report similar progression-free survival to conventional fractionation, 2 grays per fraction, but often with small increased toxicity risks. From professional experience in our department for treatment of low and intermediate risk patients, 60 grays at 3 gray per fraction is used routinely. Some words about FLAME trial. The results of the FLAME trial also indicate that current standard moderately hypofractionated 20 times 3 gray could be improved by focal dose escalation. Patients assigned to standard treatment received 77 grays, 2.2 gray per fraction to the entire prostate, and focal boost arm received an additional simultaneous integrated focal boost up to 95 grays to the intraprostatic lesion visible on multiparametric MRI. This study investigates whether focal boosting of the macroscopic visible tumor with external beam radiation therapy increases biochemical disease-free survival in patients with localized prostate cancer. So the addition of a focal boost to the intraprostatic lesion improved biochemical disease-free survival for patients with localized intermediate and high-risk prostate cancer without impacting toxicity and quality of life. And it is quite safe and effective. Kaplan-Meier curves up to 7 years for biochemical disease-free survival and disease-free survival and distant metastasis-free survival comparing to the standard treatment of 77 grays in 45 fractions to the whole prostate with an additional focal boost to the macroscopic visible tumor up to 95 grays. In conclusion, I would say that FLAME trial showed that a focal boost to a higher dose improves biochemical disease-free survival in intermediate and high-risk localized prostate cancer without additional toxicity. Late GU and GI toxicity, grade 2 and grade 3, differences were small and not statistically significant between groups. No grade 4 GI toxicity occurred. Focal dose escalation in extreme hypofractionated schedules should be further explored. As we observed a clear dose-response relation, further improvement of tumor control may be feasible when more advanced techniques allow a higher boost dose. The latest treatment trend is an escalation of dosage. Dose escalation has been proven to achieve the best biochemical control in men with intermediate and high-risk disease. Due to COVID situation, hypofractionated regimens became a treatment standard. Moderate hypofractionation up to a fraction size 3.4 gray when compared to standard fractionation for prostate cancer appears to have minimal effect on cancer-related outcomes, can be delivered with similar late gastrointestinal and genitourinary toxicity, but comes at the cost of a likely slight increase in acute gastrointestinal toxicity and without detriment to the quality of life. What are recommendations for prostate cancer treatment? For low-risk patients, in general, active surveillance is encouraged and widely chosen. When needed, there are many options of treatment like RP, brachytherapy, or external beam radiotherapy. Active surveillance is not an option for intermediate-risk patients. LDR brachytherapy can be offered for patients with good IPC score, or intermediate risk patients should be used to treat by external beam radiotherapy, highly conformal radiotherapy plus image-guided radiotherapy in combination with short-term ADT from 4 to 6 months. Does short-term ADT and radiation dose escalation to 78 grays improve the long-term outcomes for patients with localized intermediate risk prostate cancer compared with radiation alone? This EORTC trial with 12-year median follow-up of above 500 intermediate risk patients randomly assigned this trial, we showed that 6 months of concomitant and adjuvant ADT statistically significantly improves event-free survival and clinical disease-free survival. The effect on overall survival and distant metastasis-free survival did not reach the statistical significance without limited statistical power. They shed light on the important clinical question of value of ADT in men treated with radiation if dose escalation was used. So 6 months of concomitant and adjuvant ADT statistically significantly improves event-free survival and disease-free survival in intermediate risk prostate cancer treated by irradiation up to 78 grays. The effects on overall survival and distant metastasis-free survival did not reach statistical significance. So the best option for intermediate risk patients to combine short-term ADT without external beam radiation therapy in dose escalation mode. But of course, it is decision made by MDT, as we show this day. External beam radiation therapy may be chosen as a treatment option due to patient preference, medical comorbidities precluding surgical management or adverse effect profile. High-risk prostate cancer patients are treated by external beam radiation therapy, while brachytherapy boost can be added, also with long-term 2-3 years ADT. Lymph node irradiation is indicated, but it can be considered. This phase 3 single-center randomized controlled trial enrolled eligible patients undergoing radical radiotherapy for node-negative prostate adenocarcinoma with estimated nodal risk above 20% by Roche. Randomization was 1-to-1. One group only prostate, 68 gray per 25 fractions, or whole pelvic radiotherapy, includes prostate and pelvic nodes, including common iliac nodes. All patients received image-guided and intensity-modulated radiotherapy and minimum 2 years ADT. The primary endpoint was 5-year biochemical-free survival, and secondary endpoints were disease-free survival and overall survival. Whole pelvic radiotherapy also showed higher 5-year disease-free survival, but 5-year overall survival did not appear to differ. Distant metastasis-free survival was also higher with whole pelvic radiotherapy. Benefit in biochemical-free survival and disease-free survival was maintained across prognostic subgroups. So prophylactic pelvic irradiation for high-risk, locally advanced prostate cancer improved biochemical-free survival and disease-free survival as compared with prostate-only radiotherapy, but overall survival did not appear to differ. What is the optimal minimum duration of ADT when treating high-risk prostate cancer with high-dose radiotherapy? Radiotherapy combined with ADT is a standard of care for high-risk prostate cancer. However, the interplay between radiotherapy dose and the required minimum duration of ADT is uncertain. This cohort study of 3 studies totaling more than 3,000 men with high-risk prostate cancer found a significant interaction between the treatment type, external beam radiotherapy vs external beam radiotherapy plus brachytherapy boost, and ADT duration more than 18 months. These cohort study findings suggest that the optimal minimum ADT duration for treatment with high-risk, high-dose radiotherapy alone is more than 18 months, and for external beam radiotherapy plus brachytherapy boost, it is 18 months or possibly less. I think that additional studies are needed to determine more precise minimum duration of ADT. I would also like to talk about postoperative prostate cancer radiotherapy. Typical indications for adjuvant treatment includes PT3 disease, positive margins, or seminal vesicle involvement. Adjuvant radiotherapy is usually given within 1 year after operative side effects have improved and stabilized. Patients with positive surgical margins may benefit the most. Recommended dose for adjuvant or salvage prostatectomy radiotherapy are up to 72 Grays in standard fractionation. Biopsy-proven gross recurrence may require higher doses. European Association of Urology guidelines recommends to offer adjuvant IMRT plus image-guided radiotherapy for high-risk patients, PN0 with ISAP grade group 4 to 5, and PT3 plus minus positive margins. Nowadays, maybe due to COVID pandemic, more often postoperative radiotherapy is delayed and performed as early salvage. One undetectable PSA that becomes subsequently detectable and increases in 2 measurements, or PSA that remains persistently detectable after RP. Treatment is more effective when pretreatment PSA is low and PSA doubling time is long. Early salvage intensity modulated radiotherapy plus IGRT should be offered to the men with 2 subsequent PSA rises. Patients should be informed that the effectiveness of radiotherapy for PSA recurrence is greatest when given at lower levels of PSA. Most effective treatment when PSA level is below 1.5 or even 1.2 nanogram per milliliter. Unfortunately, our meeting is online, and in this case, I would like to represent what are we doing in our department. This is a case of my patient, 20 years old man in good performance status. Primary PSA was 15, digital rectal examination with no palpable nodes. Multiparametric MRI showed PRADS 5 lesion in T-zone on the left lobe. Prostate biopsy was performed and Gleason 4+3 was found. In July, laparoscopic radical prostatectomy with pelvic lymphnodectomy was performed. It was found PT2C and 1 disease. 23 lymph nodes was dissected and 1 pathologic lymph node was found. Control PSA after surgery was 0.6 nanogram per milliliter. Pelvic MRI, no residual disease in prostate bed, but 6.5 millimeters lymph node of altered DVI signal in mesorectum to be followed in dynamics. MDT decided on ADT and adjuvant radiotherapy. Adjuvant ADT was started in September. 2 months later, adjuvant radiotherapy was planned. Usually, knees and feet board is used in treating patients with prostate cancer. Immobilization devices are created to ensure patient comfort, daily reproducibility, and avoiding patient's movement during treatment. Planning CT was performed. At first, patient is positioned and immobilized. In this position, a CT scan is performed. The patient is set up in a treatment position on a dedicated CT scanner. Some of its features, it's a large aperture for our immobilization devices and a flat couch, the same as in a treatment machine. Then images of CT scan are transferred into planning system where target volume is delineated. CT simulation images are often fused with other scans such as MRI or PET scans for better determination of tumor in some clinical situation. But in this case, pathologic lymph node in mesorectum was identified in our CT scans. In this case, there are two volumes, whole pelvic lymph node irradiate 50 grays and simultaneously higher dose for pathologic lymph node up to 55 grays, 2.2 gray per fraction, and prostate bed up to 70 grays. Radiation oncologist must define treatment volumes and volumes that must be protected. The final high-dose radiation target will be focused very precisely only on the prostate gland or prostate bed, like in this picture. Common postoperative treatment was planned. Patient's anatomy and pathologic lymph node location in mesorectum allows to escalate dose in this place. So we decided to deliver higher dose simultaneously. After that, medical physicist creates treatment plan, and this plan is one evaluated and approved for treatment on LINAC. This patient has high-risk prostate cancer, node plus disease, so it is indicated for pelvic lymph node and prostate bed irradiation. Common dose is 50 grays for pelvic lymph nodes and 70 grays for prostate bed for external beam radiation therapy, and simultaneously higher dose 55 gray, 2.2 gray per fraction for pathologic lymph node was planned. Dosimetric plan was performed and it was safe due to dose volume histogram. Here it is escalated dose in this place. It look like a red dot on this picture. And external beam radiation therapy typically delivers radiation using linear accelerator. Daily prostate localization, prostate bed localization using image-guided radiotherapy is essential with IMRT for target margin reduction and treatment accuracy. Every day, con-beam CT on board is performed, and this improves cure rates and decreases complications. Usually, we perform on-board imaging before each fraction. Better imaging improved precision, put the dose when needed. Once everything is under control and then table shifts are made, we can treat safely, and it repeats every day. For additional control and patient's external movement detection, optical surface monitoring system or SMS can be used during beam on to additionally ensure accuracy. Routinely, SMS is used for chest monitoring, but also it can be used for pelvis. And the most dangerous phrase in the language is "we always done in this way." So let's go out from the box. And thank you for your attention.
Thank you very much. Thank you very much for your presentation. We have one question from the audience. Maybe Dr. Trakimas wants to ask, maybe by himself it is possible to do that.
Yes, I write the question because I wanted to be silent a little bit. What's your opinion on local stereotactic body radiation therapy, or for prostate, for as we discussed in multidisciplinary team, for example, for the local recurrence after radiotherapy, for primary treatment naive tumors?
Do you mean about recurrence after radiotherapy, or
Let's talk about recurrence and then what's opinion on primary tumor.
we have no experience about stereotactic prostate radiotherapy, but I think that it is future. Now it is performed with CyberKnife with another techniques, yeah, and with external beam radiotherapy, stereotact SRS for prostate with Linux. It's a future, but
So it's feasible, yes, but we need some experience to start it, and
we need more experience in this, and I think we need spacers for this to deliver with safety without any complications on urethra or rectum. We need spacers, and I think some technical details stop to do this.
okay, so I think I could help you with spacers, and then we can start this in the near future. Thank you.
I think we will deal this evening. This okay, Mantas?
Okay.
Yeah, thank you for the presentation. Thank you for the answers.